Hello everyone, and welcome to the WAIMH webinar series, and the second of two special WAIMH webinars around fathers and children's mental health. I'm Campbell Paul. I'm the president of WAIMH, and on behalf of the board and colleagues, the WAIMH organisation and the office, and our particular colleagues in Toronto at the Infant Mental Health Promotion Foundation service at Sick Kids, we give you a hearty welcome, whatever time of the day it might be where you are in your part of the world. In my part of the world, I'd like to acknowledge that I'm presenting here from the lands of the Wurundjeri people of the Kulin Nation, who are the traditional owners of the country, this part of Australia, and to acknowledge their elders, past, present, and emerging, and to acknowledge all of the people around the world who are caring for their country, their land, their waterways, and the environment, and their peoples. So it's a great pleasure to welcome as the convener and chair of the webinar this morning, Professor Hiram Fitzgerald from Michigan State University. Yeah, and we've had a very long and friendly and productive association over many years. Hiram's been involved with the World Association for Mental Health, and before that was a key person in the amalgamation of WAIMH with the International Association for Infant Mental Health. So Hiram has brought together a stellar group of researchers, clinicians today to talk to us about fathers and children's mental health. And at that point, I think I'll hand over to Hi, who's going to host the webinar from here. Just a reminder, actually, we'll be able to collect questions and answers from the Q&A box, which you'll see down at the bottom of the Zoom screen, and chat. And at the end of the webinar, we'll have a Q&A session with the presenters and with Hiram. So, and this is just a reminder that the webinar series is partly as well a lead up to the World Infant Mental Health Congress, which will be in Brisbane in June this year. And at the finish, I'll say a few more words about that. So, with all those words done, welcome and thank you to Hiram Fitzgerald, who's going to introduce our panelists as we go along this morning.
Thank you, Campbell. So I'm Hi Fitzgerald. It's my pleasure to welcome you to the WAIMH webinar on fathers and children's mental health. I'd like to thank the WAIMH webinar committee for accepting our proposals for these webinars on fathers and early child development. In addition, thanks go to Donna Hill and Dr. Chaya Kulkarni from the Infant Mental Health Programs at Toronto Sick Children's Hospital for their assistance in organizing the Zoom sessions. WAIMH webinars are initially open only to WAIMH members, but after 3 months, they are available to any viewer through the WAIMH website. So please encourage non-members to check the WAIMH website in May for access to all the WAIMH's past webinars. Today's webinar includes presentations on fathers and their children's mental health, both with respect to effects on children and to interventions with fathers. Presenters include Dr. Stephanie Godleski from the Rochester Institute of Technology, Drs. Kai von Klitzing and Lars White from Leipzig University, and Dr. Richard Fletcher from the University of Newcastle. The etiology of psychopathology has been strongly influenced by developmental systems views of the biopsychosocial organization of behavior, incorporating genetic, epigenetic, and experiential influences of emotional, behavioral, cognitive, and mental processes that influence and are influenced by neurobiological mediational networks. From a systems perspective, risk for psychopathology emerges from family and individual characteristics, as well as sociocultural and other contextual influences over the life course. Longitudinal research designs have substantively influenced understanding of the rich diversity of life course pathways, some of which show high continuity for adverse outcomes, and others that do not. In each case, reflecting the balancing of risk and resilience factors for children reared in high-risk families and external environments as they adapt to these environments over the life course. Longitudinal studies of children born into families with high parental psychopathology indicate that by age 5, many children have high levels of externalizing and internalizing behavior, poor value structures, difficult temperaments, insecure attachment relationships, and difficulties with emotional and behavioral control. Despite poor beginnings, however, other life course experiences can alter children's experiential worlds, exposing them to resilience, building alternatives to risk that not only affect them psychologically, but also affect the underlying neurobiological mediational systems and their connectivity with behavior and mental functioning. Clearly, by age 2, children are forming mental representations of experience, constructing remembrances of lived experience, generally referred to as autobiographical memory, with semantic knowledge and representation of events generated by self-observation, but also the shared meanings of events and experiences as defined and conveyed to them by their caregivers. Whether viewed from cognitive, social learning, psychoanalytic, or family systems theoretical perspectives, parent-child interactions contribute to the organization of children's concepts of what they are and who they are. By age 5, most children have an understanding of what they are with respect to such categories of sex, race, ethnicity, religion, height, weight, and they are also forming a sense of who they are, their intersubjective sense of self. My colleagues and I have suggested that the organization of perceptual, sensory, and internal working models of self, others, and self-other relationships become embodied into neural networks, particularly those that mediate regulatory systems and mental representations about relationships. We developed a model of the early organization of intersubjectivity that theoretically primes the child for organization of relationships, including the very young child's nascent sense of self. With respect to psychopathology, the idea is that when the child's first 5 years of life are dominated by exposure to psychopathological relationships and behaviors of their primary caregivers, the dynamics of psychopathology become embodied within the child's sense of self, others, and self-other relationships. Thus, the 5-year-old has established set points against which new self-other relationships will be evaluated and enacted. We have especially thought about this within the context of the development of aggression and violence in males and the risk for substance abuse disorders and psychopathology over the life course. Our first presenter today, Stephanie Godleski, reviews work concerning the effects of paternal alcohol use and family dynamics, beginning in infancy and continuing through childhood. Stephanie?
Thank you, Hi. As I mentioned, today I'll be talking a little bit about paternal alcohol use disorders and alcohol problems and early childhood development. And first, I just want to start by giving a little bit of information about alcohol use disorder and alcohol use. So 1 in 10 children live in a household with at least one parent with an alcohol use disorder. And there's a robust literature on the developmental consequences for children of alcoholics. And it seems that father alcohol use can create a cascade of risks throughout the family that impacts children, including deviations from typical or normative family interactions and individual development for both children and adults. However, there are opportunities for both promotion and protection within this system. And so I'm going to try to highlight, as I'm going through today, some of the areas where potentially there might be opportunities for protection. And some, might be asking, why particularly father alcohol use? Well, men do tend to consume more alcohol. They're more likely to drink it heavily and excessively, including being more likely to binge and experience more alcohol-related harm and consequences. I want to give a little bit of information about drinking risk levels, just to make sure that you understand what I mean by when I say heavy and binge drinking. So lower or moderate risk drinking would be for men having no more than 4 drinks at any one time or on any given day, and no more than 14 drinks a week. So anything above low or moderate would be what might be considered to be heavy or higher risk. So above what would be considered to be healthy limits. And binge drinking essentially would be having more than what we consider to be low or moderate risk, that 4 drink level, so having 5 in about a 2-hour range or on a given day. I find it helpful to think about it as what the National Institute on Alcohol Abuse and Alcoholism describes as it being too much and too often, as being potentially problematic or increasing risk. And why I talked a little bit about the concept of too much and too often is that we do see that there are, that father alcohol use that is heavy and episodic might have just as significant of an impact on the family system as alcohol use disorder. So this heavier use also increases risk for father health consequences. So drinking doesn't necessarily need to be to the level of being disordered for it potentially to have consequences. And interestingly, some of that risk from that heavy and potentially episodic use might be conferred even before birth. So there's been some research to suggest that paternal preconception alcohol use could impact fetal development, including impact on neocortical development, as well as birth defects. And then postnatally, we see that there's no association between parent alcohol use and child externalizing and internalizing behavioral problems and behavioral under control. And that then oftentimes we see that internalizing and externalizing is then being potentially predictive of the development of substance use and alcohol use problems on the part of the offspring. Developmental cascade models might be helpful as a framework for applying to the context of father drinking by thinking about how there might be a cascade of influence from early experiences, particularly for children's social and emotional outcomes, and also highlighting the importance of the timing of experiences within the parent-child relationship as being important to note. And as I go through today, I'll try and note some of those really important time periods that we found within the context of father alcohol. So as I mentioned, father alcohol problems has been shown to be associated with their offspring having alcohol and substance use. However, it's important to mention that father alcohol problems, even in the first 3 years of life for a child, is associated with adolescent substance use at 15 to 17. So there's something really important happening during those early experiences that might be conferring risk. And father alcohol problems typically are nested within a web of other comorbidities and circumstances that are important to note. And that there's likely this cascade of risks throughout the family that impacts children, impacting partner relationships, as well as their family circumstances. So I sort of think about it, I have dominoes at the top, so I sort of think of it as starting at like a cascade of effects, and that perhaps father drinking is sort of what helps to tip it in that direction. And so here are some of the things that I'm going to try and touch on today in terms of some of the influences and consequences of father heavy drinking. So influences on the parent-partner relationship, early parenting experiences, and really importantly, child self-regulation, which then is associated with subsequent child behavioral problems, which, as I mentioned, those internalizing and externalizing problems are then associated with adolescent substance use and initiation. Though I made it look really clean and nice and linear here, but it's likely more of a more complex web of interactions that are happening here, where if you move one of the gears, likely it's probably influencing other components within the system. So clearly that's a bit of an oversimplification of what might be happening. So I highlighted self-regulation when I was on the previous slide, and that's because I think the research would suggest that it's really a critical predictor. It's an important developmental transition and turning point for children of fathers with alcohol problems, and that it really seems like that by age 3 or 4, that this is a sort of key point in the developmental trajectory for children who have fathers with alcohol problems. So these children are less likely to experience normative declines in aggressive and disruptive behavior. And that once they're sort of at this, like having this level of dysregulation, that we see that they then continue on trajectories where they have high, stable levels of externalizing behavior problems, and then potentially are associating with deviant and delinquent peers in adolescence, and also increasing risk for that alcohol and substance use later on. So it seems like there is something really important about this period of time. And so understanding what's going on that might be contributing to child dysregulation, to me seems like a really critical component in terms of thinking about prevention and intervention for children within this context. So I'm going to discuss a few of the factors associated with father alcohol use that I think might be particularly important. And one of those things is the parenting context and parent-child interactions, and that likely this is an important pathway, and that it might be in some way potentially mitigating or exacerbating the risk of father alcohol problems. And what I want to highlight here within this figure, which on our y-axis we have externalizing behavior, and on the x-axis we have child age, that this area that I've line that I've circled now in blue is children who have a father with an alcohol problem, who we have an insecure attachment relationship with mom. And so you can see that they're at this at higher risk, even and at higher levels compared to the control group children, as well as children who have a secure relationship with their mother. So that secure relationship seems to be buffering the risk of having a father with alcohol problems to some degree. And so it's important to kind of consider some of these potentially parent-child interactions that might help to reduce or exacerbate the risk associated with having a father with alcohol problems. So I just want to talk a little bit more about those. Given that it probably is an important pathway from parent and sort of father alcohol use, and how it impacts child development is potentially through ineffective or harsh parenting, and particularly in parent and infant interactions as being really a critical piece. So alcohol problems, not surprisingly, are associated with more negative parenting practices, including poor monitoring in adolescence, but especially lower positive involvement earlier on. And I also think it's really important to note that father alcohol problems not only impact their own parenting, but also it impacts their partner's parenting. So in the case of mom, it's associated with increases in harshness, as well as decreases in warmth and sensitivity. And it's also associated with more insecure attachment. And why that's important is that maternal negative affect and lower warmth and lower sensitivity in infancy for children who have fathers with alcohol problems is also associated with higher frequency of substance use in adolescence. But as we saw on the previous slide, having at least one adaptive caregiver can be protective. So that secure relationship with mom, if it exists, can help to buffer the risk potentially of having a father with alcohol problems. I also feel like it's important to note that there could be a relationship that goes in the other direction as well. There has been some research to suggest that having a child who is more difficult or dysregulated also can increase parent drinking. And so there could be some relationship in which perhaps drinking to cope might in some way be also increasing father drinking within that context. So overall, it's important to consider potential family system influences on parent-infant interactions and child self-regulation. So one of those pieces that I think might be influencing especially parent-child interactions would be comorbid psychopathology that goes along with father alcohol problems. Substance use oftentimes co-occurs with other forms of psychopathology. And this might in some way particularly like influence other aspects of their interactions, including parenting or perhaps their intimate partner relationship. So father alcohol problems oftentimes co-occurs with paternal depression as well as antisocial behavior. So paternal depression is associated with father having higher levels of aggravation, lower warmth and sensitivity, and less child social competence, as well as elevated levels of internalizing and externalizing. But what I really want to emphasize is that antisocial behavior piece as being perhaps an important exacerbator. So a lot of it's hard to disentangle antisocial behavior from alcohol use, especially when we think about early childhood consequences, because there's a lot of overlap in in terms of the population that have been studied, given that oftentimes the fathers who, particularly in studies of antisocial behavior, oftentimes also probably had higher levels of alcohol use or met criteria for some sort of alcohol use disorder. And antisocial behavior is an important risk factor that potentially will elevate risk even more for children, especially if they have frequent exposure to a father with antisocial behavior, such as when they live in the home with that father. And so they do seem to be a really important and synergistic relationship between paternal antisocial behavior and alcohol problems, such that it might exacerbate the risk for the parenting dyad and for children. So to give a little more detail about that, father antisocial behavior is associated with, within the context of father alcohol problems, father to child hostility, and then a similar and potentially maybe even more elevated trajectory of dysregulation and emerging behavioral problems by 3, and then that continues stable level of externalizing behavior problems from there. Another important piece of this puzzle in predicting child outcomes is parent-partner relationships. And parent conflict is especially implicated in children's social and emotional development, particularly potentially leading to emotional insecurity for children. And parent conflict is associated with child dysregulation, even as early as infancy. And father alcohol problems can definitely impact and increase the likelihood of conflict, as well as the risk of intimate partner violence. And then partner conflict might then have a spillover into parent-child interactions, particularly for fathers with alcohol problems. On the flip side, though, it is likely that positive partner relationships might actually help to reduce father drinking. And so there's been some research that suggests that when there's higher satisfaction or when the more positive partner relationship, that it's then easier for a father to be able to change his alcohol use patterns. And I just want to note that yet again, antisocial behavior for a father might be another exacerbator here, and that father antisocial behavior accounts for unique variance, even in the context of father alcohol problems. And so, again, an important thing to consider. So just to try to pull it all together, I just want to talk about targeting domains that might be particularly impactful in preventing this cascade of risk. But I do want to note that there are clearly going to be influences that happen after this point, that there are going to be other developmental experiences that could provide opportunities for protection and risk. But I think it's important to think about maybe some of these early risk experiences that might in some way be creating a more problematic trajectory, or that might be making it more likely for a child to kind of continue at some of these higher levels of externalizing behavior, and then potentially be more likely to develop some sort of substance use problem themselves. But father drinking is nested within a complex system influencing early development. And I think that that's important to acknowledge when we think about prevention and intervention, that we probably will want to support the parenting dyad to increase their warmth and sensitivity, potentially their consistency, the use of appropriate discipline practices, and also help to support their relationship, maybe helping to increase satisfaction, to increase positive interactions, to help to learn conflict management skills for the couple, as well as helping them to work together in terms of being a co-parenting team, all while simultaneously potentially helping to facilitate drinking within healthy limits. And I think in terms of thinking about, particularly also given the critical nature and sort of the turning point of child self-regulation, it's really important to think about how we can particularly facilitate that. And I think one of the ways to do that similarly is through emphasizing high effective attunement and warmth and sensitivity during those first couple of years. And I think it's also, again, considering those first few years of life and potentially even prior to birth. So as I mentioned, the father drinking and alcohol problems from those first 3 years was associated with higher levels of drinking for offspring, as well as substance use. And so I think potentially targeting those first 3 years can be really helpful, and potentially even starting prior to birth during time when for some, the transition to parenthood might be particularly motivating for them to be able to make some changes and to be able to maybe change some of their health habits as well. I also just feel that it's important to note that I think this is especially an important topic now, given COVID-19, because there's been increases in alcohol sales in some areas, as well as increasing drinking rates. And there's been some evidence to suggest that it's especially the case for people who have children within their household. And so I think that given our current circumstances, it might be especially important to consider the impact of father drinking, given that maybe there might be some people who weren't drinking at particularly risky levels who may now be engaging in higher and more problematic levels of use. I just wanted to end by thanking some of the important sort of contributors and collaborators in terms of some of my work within father alcohol problems, so Dr. Rena Ida and Dr. Ken Leonard. And I want to be able to turn it over to Dr. Lars White for his presentation about psychotherapy with fathers.
Thank you very much. It's a great pleasure to be part of this webinar, and thank you very much for the wonderful introductions. So I'd like to talk to you a little bit about fathers in psychotherapy and their role in the therapeutic process, and just giving you a brief overview of what that means. I'll briefly very, very briefly summarize what we know about interventions for fathers or with fathers, as it were. So the empirical literature on this topic, which is very slim, unfortunately. And then I will segue straight into the role of the father in development, and then extrapolate from that to his role in child psychotherapy. So it will really be a point of departure, this first part, for then talking about 3 levels at which fathers need to be considered when we talk about them in child psychotherapy. So the real father is what we call 1 level, the father in the parent-child triad is the next level, and the represented father is the 3rd level. So I'll go into each of those in a minute. So starting off with psychological intervention for fathers. So this is something I'll very briefly only mention. I've the chapter in the handbook gives you a much deeper insight into this field, and it really shows that there was a phase when fathers really weren't much involved in child psychotherapy at all, or only unsystematically involved, which lasted up until about the 80s. And the basis was that mothers were the primary caregiver, and hence fathers were not necessarily, they weren't necessary for the therapeutic process. They were nice to have, as it were. The next phase was more of a with phase, where fathers were actually included, but using mother-oriented interventions, or interventions that were constructed with mothers in mind. And that's very much where we are at now. So you could say fathers were moderators of therapeutic success. That's what these findings were showing, that they were actually led to greater stability of intervention success. But the intervention itself was not, it was not formulated with a theoretical model in mind that considered fathers as such. And there were many gaps in this literature as well: early childhood, internalizing problems, just naming 2 of them. And the phase that we really want to get to now, and that's what I want to talk to you for the rest of the talk to you about, is the phase 3, where interventions should be formulated for fathers, so targeting fathers using father-tailored interventions. So this is really where we want to go, and fathers are, in that sense, are mediators of therapeutic success, and it really matters how we intervene with them, not just that we intervene with them, as it were. So luckily that was the first part of the talk. So the one that I was only going to briefly walk you through as fast as I could. So that takes me to the real content of the chapter, where we talk about what fathers actually, what their role is in development and psychotherapy. And a lot of this work, I need to maybe say before I go into this, is speculative. I mean, we are aware of the fact that fathers also have a role to play as a role that's similar to what mothers do, as you can see in this picture. But there are also distinct roles that fathers enact, and that's really where we would like to move the field towards, considering those roles also within therapeutic intervention. And many of these points, of course, that I'm going to mention apply to the father as a principle as opposed to the actual father, which I think the point there is that this father as a principle can be taken on by either parent, including, of course, parents in homosexual relationships. So we're not making a claim that this is necessarily the father's role, but there is some evidence to suggest that potentially fathers might be in a very good position to fulfill this role, possibly in a slightly better position than mothers usually. So let me take you there and walk you through this, starting with an example. So I'm going to offer an observation of a father-child play interaction where we're seeing, or we saw a child, an 18-month-old boy, interact initially with his mother. And the mother was playing with the boy in a very attuned way, trying to scaffold her son towards engaging in pretend play, the way that we know it, as it were, and the way that we expect it as developmental psychologists. And she was saying things like, look, you can use this pitcher and pour lemonade into the cup, and then you can drink the lemonade. Yum, this tastes so good. And she was trying to really animate the child into engaging in pretend play. And the boy actually seemed quite confused by all of this. And he repeatedly just replied with nothing, nothing. And the mother was very, very patient and attuned and tried and tried and tried. But she was just not getting there, as it were. And once the father entered the play, we saw some very, very different behavior. The father was more or less unresponsive to the boy's emotional state and just following his own agenda. And he took the cup that the mother was using in the initial interaction, and he took the cup and shouted toot, 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 as if the cup were a microphone. And then he moved to an even higher level of decontextualized symbolic play, we would say, where he used the play object as a trumpet or as a microphone, sorry, and he was not using it in a way the way that it looks, as it were. So it symbolized something that had a very different outward appearance. So he was almost taking the child up a notch. And what ensued was joyful, cooperative play, singing, shouting, using the toy cup as a pretend microphone. So this really, we feel, contrasts these two types of play quite nicely, we hope. And this is, I'm going to walk you through the model that we've extrapolated from that interaction, as it were, at the risk of generalizing from a single interaction, of course. But I do believe that there is a kernel of truth in this interaction that we might be getting at. So you could say that initially what we saw is the father, the child showing a mental state and then communicating that to the father, and the father perceives these affects or thoughts of the cup, for example, representing there being something within the cup, a fluid within the cup, and then he decouples himself from those affects and thoughts and the related expectancy that the child brings to the table. And then he creates alternatives in his mind that share one thing in common. They violate the child's expectancy. So he kind of playfully and creatively surprises the child and challenges him or her with his thoughts and affects. And this is very important, that all of this happens in playful interactions, of course, unlike a distressful interaction where you see which you see, for example, in a strange situation. That's not the kind of behavior that we see under those circumstances. This is really something which Daniel Paquette has talked a lot about, which occurs in play. And so the father really inserts his own mental state at this point, as it were, and then he brings it into contrast with what the child is doing, and just brings in a completely new idea of his own. So using the cup as a microphone, as we just had it in the example, and what happens is that the child really internalizes this dual perspective, as it were. So a self-other differentiation that occurs, and perspectival flexibility. Also, we've seen self-oriented social competence, as it were, that might stem from some of this process, where someone starts to, or a child starts to learn to stand up for her own or his own ideas, and contrast them with the partner. So this is the model that we came up with based on the literature, and it's obviously inspired a lot by Daniel Paquette's work. And this led us to propose 3 levels that I already mentioned to you. And the first level is very close to what you just saw in this example. The first level is the level of the real father, where we feel therapy and intervention needs to act on. And this is the paternal challenging behavior. And we can also maybe call it the yes, you can role, as it were. So things like this, and this is a picture of me throwing my own daughter up in the air. So something that I feel I'm quite close to at the moment, having two daughters in this early window of development. What we know from the literature, and some of that was already summarized by Hiram, is that fathers promote exploration. They tend to. The paternal challenging behavior also protects against child anxiety, which is quite interesting. That's something that appears to be more strongly the case for father challenging behavior as opposed to mother challenging behavior, where there's mixed findings, although there is some data to suggest that mothers might be able to compensate if fathers lack some of that challenging behavior. Something to bear in mind here, though, with the challenging behavior is that there might also be some reverse effects. So we assume that maybe there is some causality here, but of course, temperamentally very fearful child may also evoke less challenging behavior from their parents. So this is very important to bear in mind, that we are not yet at the point where we can necessarily make these causal statements, but nevertheless, findings are, and the evidence is growing that these factors play a big role in child anxiety and might be very helpful to consider in therapy. And something that's related to that, another layer, as it were, that we need to consider in therapy is the father and the parent-child triad. So this is a concept that Kai von Klitzing also worked on a great deal since the late 90s, together with French colleagues such as de Pulsange and others. And the findings in that area really reflect the notion of triadic competence, which you can summarize as the ability to contemplate family relationships without excluding yourself or your partner or your partners from the relationship to the infant. So the triadic competence is something that you can try to assess within an interview setting, and has been done. And the prenatal paternal triadic competence has been found to be a predictor of postnatal triadic functioning in a play situation. So triadic functioning then being rapid, for example, rapid back and forth gaze shifts between both parents and effective signals directed at both parents simultaneously, so-called triangular bids. So it appears to be the case that especially the paternal triadic competence is foundational for this sort of capacity. And also later on, when we go into this triadic functioning, it's a predictor of theory of mind. So it really does have knock-on effects for later in development. Now, I just want to briefly link that a little bit to intervention. And I'm going to draw on an intervention or an example, a case study that was published by Perez in a very nice book on fathers and child psychotherapy. And in this case study, Perez talks about a borderline mother who really is a gatekeeping mother, as it were, who tries to prevent any sort of interaction between the father and her 2.5-month-old son, who she feels is very damaging to the relationship, and who plays too energetically, she says, with her son. And there's she describes a situation within the consulting room that emerges where the child is withdrawing into an autistic state. And what she does then is she speaks on behalf of that infant, and she wonders whether their son may feel as if it was all too much and was trying to escape, if only with his eyes and his mind. And what she's trying to do is she's trying to activate the father, the withdrawn father in this situation, who has this is something that's quite typical within borderline personality disordered patients and their young infants, is that this what I already called gatekeeping, but they essentially exclude the father from the relationship, and that's exactly what happened in this relationship with the father. And here was Perez trying to reactivate the father, as it were. So she's trying to harness the father's concern for his son, and it's kind of like an activating gentle push to overcome his own fears and then become more involved. And in the end, she describes an episode where the father is actually engaging in this sort of activation play and is very proud that he is now able to be a bit more involved within the parent-child relationship, and still be also ensuring the child's safety, so that nothing actually happens. Because that's a very, very important point when it comes to activation play, is that obviously just encouraging it it needs to be done with a lot of care, because it can come at the risk of not being attuned to the child and the risk that one is exposing the child to. The final level that we talk about in this chapter that is crucial, and again it links with what Hiram was presenting initially, is the representational role of the father. And again, that might just be more distinct, a role that is slightly distinct from that of the mother. As we can see in these pictures, more of an activational role, one that promotes sense of agency or self-confidence, separateness, or this self-oriented standing up for yourself that I mentioned earlier. And of course, the idea here is that of internalizing this kind of sense of agency and then carrying it forward into new interactions, new social interactions, where a child may be more courageous, just approaching others, feeling that they can have a sense of self-efficacy, as it were. And this is obviously not something that is exclusive to the father relationship, by no means, but as Herzog suggests, and we quote him a lot in that chapter, there may be a certain division of labor between mothers and fathers. And of course, there might be more of a role for the father to promote this, to promote the exploration side of things, as opposed to the safe haven side of things within the sort of attachment framework. And this is something that the father then carries forward from, it's initially external and then is eventually internalized through development and then carried forward into these new interactions. And there's not a great deal of evidence for fathers at this level, but there is some emerging work about the father and the child's mind, as it were, with positive father representations and coherence in father stems being related to secure attachment of the father, so that there seems to be some intergenerational links there. That less child anxious or withdrawn behavior is also, again, something that we see when children show more positive father representations in father stems. So sorry, when I didn't explain father stems to you, but father stems being child stories that they complete after having been told a story stem that's a story beginning, as it were, and then we measure on a very, very accurate level exactly how many positive representations they show per story. And then they also are associated with better teacher-rated child socialization. So there's a couple of hints there that the father may play a very fundamental role in promoting these kind of adaptive behaviors. Now, with regard to mothers, there's even less evidence. There's primarily theoretical work suggesting that there is no such thing as a mother-infant relationship. So this is something that that Green said when drawing on Winnicott and the famous quote, and basically trying to poignantly say, well, we can't just talk about mother-infant relationships when we talk about the child's upbringing. We also always need to consider the father. And there is some, but only very little evidence from pioneering studies showing that maternal triadic competence leads to an increased postnatal father-child or better postnatal father-child interactions, suggesting that the mother has to make room for the father in her mind, as it were. But in general, there's a scarcity of evidence. And this is really wrapping up on that point, and then I'll be happy to take questions. we can obviously see this representational level also within therapy, and what the model that Tanja Göttgen and Kai von Klitzing developed in Leipzig makes heavy use of this concept of the triangle of psychodynamic constellations. And a crucial part is this idea of the relational symptom and the therapist-child relationship. And both of those aspects can really, they talk about the transference relationship and how the father might be transferred also into the therapeutic relationship. So in a case study from their book, Julian, for example, he is a father substitute for the mother. He has anxiety about a boundary setting third, and surprise, surprise, what happens is that Julian then treats the therapist in a way that he also excludes her, and he pretends to shoot her. The mother bursts into the room, also tries to sort of exclude the therapist, as it were, and make sure that the relationship doesn't emerge. And then Julian also dominates the therapist, and so on. So this is something that that is quite complex when we talk about the transference relationship and how exactly it enters the scene. But the father needs to be considered here, and sometimes the therapist also takes on the role of the father. Okay, I'll leave you there. I know that was a lot to take in, but the point was really that the father has a role to play at different levels in child intervention, and we need to take those into consideration: the activation role, the role within the triad, and the role of the represented father. So thank you very much. Needless to say, all of this work couldn't have been done without a fantastic research team headed by Professor von Klitzing, and looking back over the years, also the work of Tanja Göttgen and Franziska Schleinstock-Schuska in Leipzig. So thank you very much.
Thank you very much. Thank you very much for this opportunity to talk to people about this important topic. Good morning. It's morning here. I know some of you are in different time zones. Let me first acknowledge the traditional owners of the land where I'm speaking from, the Wapakul and Worimi people. Pay respects to their elders, past, present and futures. And also acknowledge all the work that goes into setting one of these up. Hi, and Donna and others, thank you very much. I want to talk about the community context of reaching men in the perinatal period with information and support. So this is quite complementary, I think, to those presentations we've just heard. I'm thinking, though, of the Australian context here. So I'm not trying to speak for other locations. I'm telling you what we've done here. My question is, what's the service context? What do the men want? And then how can we, without trying to define we, provide the information and support they need? Just to give you an idea for comparison, the public health service is one important context. Sorry, I didn't think to include Germany in this, but the data I have available was for the US, UK and Australia. And we sit somewhere between those two types of provision of public health services. So we have almost universal public health insurance. And in the hospitals, for example, around birth, we have hospitals that are 97% of Australian mums give birth in a hospital, and 75% of those are in public hospitals. We have maternity services that have developed over a century, initially starting off with concern about infant mortality and fallen women, so to speak, and have developed into maternity services. They operate around the country supporting mothers through birth and postnatally. COAG is the Health Council for Australia. That's the health ministers from each state meeting to make national policy. And in August 2019, they approved women-centred care as an important policy directive for Australian health services. By that, of course, they intend to give women a say in hospital settings where medical professionals make a lot of decisions. And that was the purpose of it. It is not intentionally excluding fathers, but unintentional exclusion of fathers is common, as you would know. So that's an important part of the context for reaching fathers. When I talk to fathers in the antenatal classes, so this is often about 6 or 8 weeks before the birth, and they talk about their own fathers who wouldn't have been in a fathers group. This is a group of dads who've come with their partners to a parenting or pre-birth set of talks run by midwives and antenatal educators. And they are quite aware that their fathers were in a different situation, often not around so much in this early period. And so the question about why do it different to your dad, who they acknowledge their dads were men of their time, so it's not critical of their fathers. They are quite aware that community expectations have changed and that now it's expected that fathers do more. The second thing that comes up in that discussion is their partner's expectation, not always expressed so emphatically as that. She'll kill me if I don't. The third thing that comes up, though, is something that seems to reflect, I think, a cultural change, and that is they want the connection with their baby, with this baby that's about to be born. However, this cultural change that's occurred, I think, in a generation where fathers are ready to express the idea that they want the connection with their babies. When further on in the discussion with dads before the birth, say, how much time will you take off? The very common answer is 2 weeks. And that is the average for Australian fathers, that they have 2 weeks off after the birth and then return. And since 2013, there's been 2 weeks paid paternity leave, paid at the minimum wage, so not a very attractive option. 2 weeks for fathers and 18 weeks for mothers. When I ask, okay, you're going to take 2 weeks off, what are you going to do in that 2 weeks? A common response is whatever she tells me to, or what she says. And some may think that's a wonderful reflection of how he respects the mother's knowledge. But I would say that that means that he doesn't have a clue. And it reflects this gap in fathers' knowledge and understanding. Fathers do want the connection with their infants, but they don't know how to actually affect that. They have no understanding, or that's putting it too bluntly. They aren't clear at all about how attachment works. So if you ask the dad, do you think you're important to your baby? They say, well, of course I am. And they say, well, how? And then they fumble for some explanation, really. They also are unaware where to get help. We have national helplines in Australia, free telephone services that you can call and have a trained counsellor walk you through trying to figure out what help you might need, which is often directed back to a general practitioner or a psychologist. And that's available, but the numbers of men who call that are small. And the third area that fathers aren't clear about is how the parenting team, just as Lars has been demonstrating, how the parenting team matters to their baby, how they cooperate around the infant. The other part of the context in the community is the attitudes and perceptions of those people, the dads and their partners. 2016 survey, which was representative in terms of age and location, asked dads these questions and had these very high response rates. As you can see, that dads, of course, find joy in their role. But they also see themselves as the one who needs to be the rock in their family. And their approach to stress and difficulty is to get on with it. A different survey, again, broadly representative, asked mothers and fathers, or rather asked men and women, can fathers have depression before and after the birth and anxiety? And only 30% said yes. About 40% said no, and about 20% said no, and 50% said they weren't sure. The professional context is that perinatal services, as Lars expressed very eloquently, are built around mothers. That although fathers might be included, the service model is fathers. And there's an important difference in that fathers don't need to attend health services for pregnancy in the way that mothers are. We have had a lot of attention, appropriately of course, to family violence and intimate partner violence. And the response in attempting to address that by screening mothers is for hospitals. Remember, where 97% of our mothers have their baby. Hospitals have protocols which sometimes say to mothers in a letter before they come in for their antenatal visit, please don't bring any males who are over 12 years old with you. Or they might wait till the mother and father have come in and then say to the man, could you please wait in the waiting room while I ask your partner some questions? While I deal with her health. They probably put it very neutrally. But the effect is that they take the mum into a separate room to ask her about domestic violence. They, to date, have had very little incentive or innovation in doing something with the dads while they're sitting in that other room. And they don't, for example, give them the Edinburgh depression screen, which mothers are given at that time, even though there is awareness about father's depression, some awareness. At this stage, there's no effort there. And there's no equivalent for women-centred care. You can imagine, I think, the puzzled expressions you might get if you asked health services, could you please explain to me how your men-centred care works in this birthing suite? That difficulty we've seen before in Australia. We've had a women's health policy for many years, and in the 90s there was a move to develop a men's health policy, and the same response happened then, where professionals and policy people at various levels said, what would you want a men's health policy for? You know, men are doing fine. They get everything already. It's women who've got to struggle for healthcare. So there is a perception that women need particular support at a policy level and men probably don't. The last area of professional context, of course, is the research base on which much of this is standing. And here the issue is not just that there's not much research, but the difficulty, if you've been writing in this area, you'll know, you want to see what the literature says about fathers in some parenting context. You'll see lots of papers that say things like this. This randomized controlled trial by researchers who by no means are novices. And that paper that is headed that it's for parents with mental health problems and young infants includes data only on mothers. And this is not an intentional thing, of course, to not talk about fathers. It's an invisibility problem rather than a discrimination problem. And I think the change that would assist the development of fathers is for editors of these journals to have a more proactive approach to making papers, not just their titles, but also their content, If they use the word parents, then it should talk about mothers and fathers. Otherwise, it should say mothers, if that's who the group of participants are. So I think that's a change that could happen at various journal levels of editing. So in that context of a professional mother-focused services, of a community that doesn't particularly see fathers' mental health as an issue, and including fathers themselves, to develop community programs, the usual approach in Australia has been for it to be focused as a father program, often group-based, and with probably a half-life of maybe 1 or 2 months. In that program start with the enthusiasm of an individual or small group, runs for a while, runs out of money and stops. Then another one starts. And without taking anything away from those programs, which I think are important, I think what they miss is a population approach. And I think a population or public health approach would say, well, how many fathers are there? For example, with a baby being born this year, what are we doing for them? Rather than noticing that you have 15 fathers in a program and thinking, well, that's great, we've covered that area. Our approach, which of course isn't meant to be prescriptive, our approach was to start with depression. Depression has the advantage of being recognised as a medical problem, as a public health problem, something that involves the community, like the whole population, and health services have already dedicated resources. This is a paper we published on the longitudinal study of Australian children data, modelled on Ramchandani's 2005 paper, which are similar results. That provides the sort of evidence to at least start. And the key point here, of course, is that we are not saying you should pay attention to fathers because they are in trouble, because they might feel miserable and isolated or anxious. We're saying that you should pay attention to fathers because that will affect the baby. And that is a much more palatable approach we've found with health professionals and with services. The issue of trying to get fathers to come to things, I now have maybe 30 years experience of the frustration of having brilliant programs, well designed, with fantastic opportunity for fathers and trying to get them to come. So this is not fathers turning up for therapy, this is fathers from the community coming to some sort of parenting intervention. There is a stream of very good programs that don't have many dads turn up. The way that this program developed was through an innovation grant from Movember and Beyond Blue, and it was to trial text messaging to fathers. So not an app, not a native app that lives on your phone, but a web-based phone optimized program that sends messages. And the beauty of the program, as we understand it, is that it's simple, that it's not intrusive, it's simply a text on your phone, and that you don't have to do anything. The three foci of the program are attachment or father-infant attachment, and that's advisedly put. These are two examples of messages that come. You can see that the message comes from the baby. This is born of the experience of recruiting dads, that if the invitation comes from their child or baby, they are more likely to respond. And also it supports the idea of the father-infant attachment. The co-parenting messages, the second theme, emphasises team parenting and the idea of cooperating with your partner. And we didn't expect, when we first ran this program, we didn't expect dads to talk to their partner about the messages, particularly. We were busy communicating with fathers. But what we found in the early interviews was that almost all dads talk a lot about these messages with their partners. They're a conversation starter rather than an answer in themselves. And the third focus on a soft focus, if you like, on fathers' depression, anxiety, is to address things like exercise and diet, as well as seeking help and seeking support from others. About a third of the messages have a link to an online non-profit resource, not designed by us, mostly public resources that you'd be familiar with. Every 3 weeks they get a mood checker, and the mood checker, again, is a very simple affair, not the sophisticated ones that you can find on native apps. The idea is simply to normalise that things might be difficult. So each of the mood checker messages starts off by asserting that this sort of thing is common, and then asking how they're going. We want to raise their awareness and link them to resources. The weeks that are listed here are the weeks in relation to birth. The messages, the 240 messages, are linked to infant development, because the dad, when he enrolls, puts in the expected date of delivery or date of birth. He can enrol from 12 weeks gestation and can enrol up until 24 weeks post-birth. And the messages continue until the baby's 48 weeks. That's a lot of talking to dads, if you think about it. 3 messages a week, roughly, sometimes for 18 months. So we see, what we think we see is a cumulative effect of support. On the right of this slide, you can see the sort of, when the message arrives, it says interactive mood checker. And the statement will say, some dads find the lead up to the birth really stressful, for example. How are you going? And then it will have a URL to click. And when they click, this image would appear on their screen on their phone, and then they would select 0 to 10 on the screen and be taken to the next level. There's only 3 levels, so it's not a very complicated system. The third level, if they say they're not doing well and they don't have anyone to talk to, it sends them to a men's line, mental health line. That is, it gives them the URL to click. And we do it that way because we can track when they click a URL. If we give them a phone number, we don't know if they actually rang anybody. Exit interviews have, well, people who agree to an exit interview, as you would imagine, are usually fairly positive. And we get very little criticism, and we have very high retention rates. Between 85 and 90% of dads who enrol stay until they run out of messages rather than exit. And we remind them all the time, you can text back stop and we'll take you out. So these are messages that dads have nominated that they can recall. This first one is quite common. There are messages in there about putting a baby down, and if you're thinking you're going to do something stupid. Partner messages about touch, and the idea, as this third dad expresses, that the message, they say in one way or another, is one of the few things, or often the only thing, that they get that's looking out for them personally, looking out for them as the dad, rather than addressed to generic parents or others. We currently have about 3,000 fathers enrolled. We're testing whether this, well, in conjunction with the New South Wales State Government Health Department, we're testing if this is an effective way to screen fathers for depression, because we already have national screening for mothers. And by screening, we mean we've included the K10 in the program, where dads complete the K10 as part of the program, and then they're escalated if they're severely distressed. A second part of the research is to use stillbirth messaging, or messaging about stillbirth, which is an important national concern, and whether we can raise that, and whether we can develop a message system for dads who experience a stillbirth. And the third is to link them to fathers groups. which we see as an important part, even as part of a population approach, some online, some in real time. We've translated the messages into Swahili, and fathers in Nairobi, informal settlements, as they're called, where they don't have running water, where they have intermittent electricity, but they do have mobile phones, and majority have Facebook accounts. We're delivering messages to them. We should start at the end of this month. And in Colombia, we've developed a Spanish version, or we and associates, and I haven't listed all those people, of course. There are many people involved in these activities for fathers around Bogota. Thank you.
If there are any questions, we can do those, but I'd like to give Kaya a chance to comment a little bit on, and I have a question for Kai actually, and Lars, but Kai especially. In the work that you do, working with fathers and the little guys, do you find a spin-off of enhanced marital quality as a result of that?
You mean whether including the father is opportunity to improve the marital quality?
Yes.
Yeah. Yes. Of course, we see a lot of families with a high level of conflict, I must say. Some of them are already separated, and so sometimes it's really difficult to have an impact on that. But if it is possible to have them both included into a therapeutic process, let's say for parent-infant psychotherapy, I think, yes, I don't have data on it. We have not measured any outcome of that, but in my clinical experience, I think yes. If it is possible to include them both, but sometimes even we see, for example, in a recent focus group, we have focus groups on psychotherapy with our preschool program. And from time to time, we see even parents who are separated, who are divorced, separated. And then we try, nevertheless, to include the father and try to bring them together, because they might be separated as partners, but they stay parents, so they have still a co-parenting task. So this sometimes is also an effect that then really the possibility to continue to be parents together, although divorced or separated, is sometimes an effect of including father into the therapeutic process.
I have very little to add to that, Hiram. Thanks. Except maybe that we also have a program where we're now treating maltreated children as well. And obviously in this context, the father typically is sidelined in a very strong way, and then we find it particularly challenging, but sometimes also particularly important, to at least contact the father, and for the therapist to have met the father, even if no contact is possible, just in order for there to be a representation within the therapist's mind when they approach the child, and for the child to know, okay, this therapist has actually met the father. And having made up their own mind about the father, because there is a lot of biases and a lot of defenses on behalf of the mother sometimes, and this is a very tricky situation when there's a lot of blame involved. What the father has possibly done, but possibly also has not done. And this is very, very important to still establish a relationship, as it were. So that's just something that I thought might be helpful to add. But I hope I haven't. I think if Hiram Klitzing wants to add more, then.
No, it's okay. I have a question to Stephanie. Do you have any experiences, clinical experiences or data or something like that on substance abusing mothers and their impact? Because it's a lower number clearly, but it exists. And if yes, if you have any experiences with this situation, differences? I mean, is the impact going into different directions, substance abusing fathers compared to substance abusing mothers?
Yeah, it's a great question. Actually, a lot of the work that I have done particularly has focused on mothers and particularly other substances other than alcohol, and with an emphasis particularly on cigarette and tobacco use. Within the if we think about, I'll go back a little bit just to thinking about alcohol use, that there does seem to be enhanced risk if both are substance using, and that particularly with alcohol, it seems like that might increase the risk even more if both are. There's a little bit of, it gets a little bit interesting because one of the effects though is that sometimes when two members of a couple are both heavy drinking, they actually have higher relationship quality and are less likely to separate. And so one of the things that's sort of been interesting to me is how that fits sort of in that whole dynamic of kind of things that I'm interested in terms of the conflict and co-parenting, that maybe if they have less conflict, but are they still maybe being an effective parenting team? And I think some of the research would suggest that maybe not so much. And then for moms, I think there's pretty similar effects in terms of their substance use, in terms of similar sort of disruptions in terms of parenting, and maybe more harsh and less sensitive and warm parenting, and disruptions in self-regulation. And I think that can get even more complicated and maybe exacerbated, especially if mom was using substances prenatally, and that in some cases, I can think that kind of creates some fetal programming as well in terms of, and susceptibility that may make infants even more prone to some of that dysregulation. But I think it's at least similar in terms of some of those that cascade in terms of it impacting temperament, and that potentially being buffered by positive parenting. I think some of those effects are fairly similar.
Thank you.
I've got a question, or two parts. I was just thinking about the family therapy movement from the 1980s, 90s, early 2000, in child and adolescent mental health, and to some degree into infant mental health. What's happened? Why aren't we using the learnings from Bateson going way back about the importance of the family as a unit and bringing the father in? Why is that so hard, as Elizabeth has done and Kai's done? Why is it so hard to bring into our work with infants and families? Where is the impetus from the area of family therapy gone? Maybe I'm being too pessimistic, but Richard might think I'm not being pessimistic. I don't know.
No, I think there are deep barriers within clinicians to picking that up, and one of them is just a very straightforward lack of resources, so that none of the clinicians we talk to say they don't have enough to do, and they wish they had another set of parents to deal with. So I think there's simple answers in that way, as well as people's established maternal focused treatment models.
Yeah, there are also societal barriers, especially in troubled families where there are young children. So if courts get involved, the courts are deferential to mothers. And there are other barriers that are imposed on men in those circumstances, fathers. So there's also a societal component, as you pointed out, I think, in your talk, Richard, about and using poor Peter Funny, using one of his articles to a pet peeve of mine too, when I was editor of a journal, that parent almost always means mother. So.
But nevertheless, I think that the family therapy movement has been very important, and without that, we probably wouldn't have parent-infant psychotherapy, because for traditional psychotherapists, especially psychodynamic psychotherapists, it was very unusual to have more than one other person in the room. So, but with babies, that's not possible. I mean, have the baby alone. So they had to, the first step was to include the mother, yes? So you were threesome, therapist, mother, and baby. And I think without family therapy experiences, that wouldn't have been possible. And now the next step was then fathers to come in and so on. Even sometimes siblings is also important. So the treatment room starts to get crowded, you know, and we are not used. We didn't learn that in our training, you know.
Well, but we often did learn it in our training. When as young child psychiatrists, we had a very strong, for me in the 80s, 90s, early 2000s, strong influence of family therapy, but it hasn't translated into our ongoing practice on the ground level. And I don't know why.
I just want to, I was really inspired by, Richard, your work in terms of thinking about meeting sort of fathers maybe where they are, right? And that by going to them in terms of sending text messages and kind of allowing them that, having that opportunity, because I think I found that sometimes it's really difficult to get anyone to come in sometimes, but in particular to get fathers to come in. I think that's because some of the barriers and perceptions. And I think that it's really an amazing idea in terms of maybe thinking of other ways to incorporate fathers that might be meeting them more where they are, and hopefully moving things in the direction that makes it more comfortable and breaks down some of those barriers for more caregivers to be involved in psychotherapy and in any sort of treatment that we might have.
Thanks very much for that, Stephanie. There's also a comment there from someone who said they really appreciated hearing Richard talking about the value of perceived support through the web app, and given the invisibility of fathers in research, a simple time message might be a powerful thing to include in people as they're designing research with fathers, to bring them in. And the questioner says this is a really great opportunity to innovate therapeutic approaches for fathers. And a plug here, this book contains quite a few innovative, of course, and well-researched and conceptual papers. Epidemiology, there's a wealth of experience here in this book that Hi and Kai von Klitzing have edited, and I can thoroughly recommend it. And a number of the authors are represented on the panel today. Actually, I shouldn't be too pessimistic about work with families through infant mental health. As Kai and Lars have demonstrated, there's really innovative work coming out of Leipzig. And I know here in Melbourne, we're really appreciative of the work that has made its way from Switzerland, where Kai and Elizabeth Vivaz were working, up to Toronto and back to Melbourne. So we're really excited about using reflective family play as a family intervention, bringing fathers in. And COVID has provided, the pandemic has provided new opportunities. So in Toronto, Diane Phillip has been using family play for infants, bringing the fathers and the mothers in using telehealth, and we're certainly doing that here. We'll have another training with a number of clinicians using with Diane Phillip, bringing fathers into the therapeutic room in a infant-focused intervention through telehealth. So, and I think we'll have to build in text messaging as part of that process of cementing the therapeutic relationship as well. I realise we're coming up to time, although really appreciate any final thoughts, summing ups, commenting on our discussions from the panel.
I think this would be a good time to put a plug in for continued conversations that will take place in Brisbane.
Yes, thanks very much. So we're very excited about the Congress, although very disappointed we weren't all there in Brisbane in June last year, but we hope we're going to have a good number of people on the ground in Brisbane. So we've got a hybrid Congress planned for June this year. So you can come online, you can be there in person, and you're also able to view all of the presentations, the short presentations, the webinars, the symposia will be available for all Congress registrants for 6 months or so after the Congress. So it'll be an unusual Congress because you won't have the same level of conflict. Will I go to this one or that one? You'll be able to choose whatever is of interest to you. But in Brisbane, we'll have a regular on-site program through the middle of the Australian time zone, the Asian Australian time zone, and there'll be presentations for the Americas, that time zone that'll be in. You don't have to get up too early or go to bed too late. And similarly, there'll be a group of presentations adjacent to the live ones that'll be comfortable for those in the European, African time zone. So it should be accessible to everyone, we hope. So we're hoping for, and the fee, of course, for being online will be significantly less than being there present. So we're really excited. We'll have the same plenaries. We'll have lots of opportunities for chat through smaller and larger Zoom groups. We'll have some sessions where you can meet with the keynote presenters and some of the people presenting the workshops and the masterclasses. So we're hoping it's going to be as involving and maybe more so than you might have had even in face-to-face. So maybe it's time to wind up. And someone was asking about Diane Phillip and reflective family play. And Donna was saying that indeed the first of our WAIMH webinars included Diane Phillip talking about that very thing. So if you go to the WAIMH website, you'll be able to access that webinar now. Colleen, who's the person asking the question. So again, we'll make the most of this horrific COVID pandemic, and hopefully it'll bring even more people from distant parts of the world to share where we're up to with infant mental health. And from today's theme, looking at new and creative ways of involving fathers in the therapeutic work, involving fathers in the important work of caring for infants and being part of the life of their baby from the beginning, from before the beginning. So again, thanks very much, Hiram, for the idea, the initiative, drawing people together through the publication. And we look forward to catching up with everyone at the Congress. Please come back to the website and share that with your friends as the previous webinars are freely available. And thank you very much to each of our speakers. Yeah, Lars and Dr. Godleski and Richard Fletcher, thank you very much for your presentations. And thanks, Hi, for being the past president and kindly paving a very creative and innovative WAIMH for our members to enjoy and people beyond. Thanks to Donna and Jaya for the absolutely crucial support for getting the webinar off the ground and functioning. And I hope everyone has a good evening or a good day, and we'll catch up with you in Brisbane, but keep your eye on the webpage.